Hi, everybody. Welcome to Kaiser Health News and California Health Line's Facebook Live chat about opioid addiction, treatment options, and access to those treatments. If you have a question, please go ahead and feel free to post it on our Facebook page. I'm Emily Bazar. I'm a columnist at California Health Line and Kaiser Health News. And this is Brian Rinker.
Hi.
Brian's a contributor who's written some really dramatic stories about opioid addiction. We're going to be discussing those today. In addition to being a journalist, Brian has a master's degree in public health, and he has some personal experience with heroin use. Brian, let's start by you telling us a little bit about your personal experience.
Yeah, thanks, Emily. I'm excited to be here. And yeah, besides being a reporter, I do have personal experience with heroin use. For most of my 20s, about 9 years, I was an IV heroin user. And about 5 of those years, I used heroin every single day, and I did a lot of things that heroin users do. I lied, I stole, I kind of manipulated everyone that loved and cared about me. And I ended up going to jail. I went to rehab. I've tried a variety of different types of treatments during that time to get me off heroin. And yeah.
So you said you used for many years. When did you stop, and what was the bigger epidemic, or was there an epidemic at that time?
Yeah, so during that time, like from the moment I started using heroin to the moment I stopped, which is about the end of 2008, I didn't really get into the opioid prescription pain pills, but during that time, like the number of prescriptions and the number of overdose deaths, opioid-related overdose deaths, skyrocketed. They quadrupled during that time that I was a heroin addict. And then after that, things just got even crazier. People started switching to heroin, and then we started to have these really high annual overdose death rates.
Yeah, that's right. I think 2016 is the most recent year we have statistics for, and in that year, more than 42,000 Americans died from opioid drug overdoses. Do you know the numbers or what the situation is in California?
Yeah, so in California, it's kind of considered to not be as hard of hit as some of the other parts of the country, but still, like in 2016, there was a little more than 2,000 opioid-related overdose deaths, which is still a lot of people.
Yeah.
And some of the rural counties and rural areas in California have overdose death rates that are comparable to some of the places like in West Virginia and other Midwest and East Coast places.
So speaking of overdoses, I'm going to ask another personal question. Have you ever overdosed yourself?
Yeah, I mean, I did a lot of my using by myself, and I think that I overdosed all the time and just came to and just wasn't really aware that I had overdosed. But I do have there was a specific time where I did some heroin and I just kind of fell to the ground. And I remember waking up, or I remember opening my eyes, and I had my friend who was sitting on top of me, and he was slapping me, and I couldn't hear him and I couldn't feel the slaps, but I knew that he seemed to be freaking out. And I was just like thinking, why is this guy freaking out so bad? You know, I'm just chilling. And then I kind of came to, and he told me that I had turned blue and he thought I was going to die.
So you had no knowledge that you had overdosed, it sounds like.
It was just like going to sleep, and then I kind of just woke up, and I was just one of the lucky ones that got to wake back up.
Yeah, thank goodness. Right now in the news, we're hearing a lot about this drug called naloxone, and this is an overdose reversal drug, an antidote to overdoses, essentially. Did you have naloxone? Did you carry it with you at that time?
No, it wasn't. I didn't really know about it back then. It wasn't as big news as it is today. But I knew that paramedics in the area that I lived carried it, and that they could reverse an overdose pretty easily, and that there was no reason to let like your friend die of one, because you could just call 911 and they'd come and revive them. But today, they give it out and at needle exchanges to heroin users like I was, in the Bay Area is one place that they do it.
Right, and I know that in more than 40 states, including California, naloxone is available without a prescription, so you could go to a pharmacy, theoretically, Walgreens or CVS or something like that, and buy it without a prescription.
Yeah, I've heard that too. I've never actually gone in and bought any, but it makes sense. Like, if you have loved ones that are using opioids, or you're hanging around people that you think may have an overdose, to carry that with you and to go get it. And yeah, for a heroin user, it might be a little too much money to go and pay for it if you're kind of struggling every day to like survive on the street and get high. So it seems really important that they give it away for free at these needle exchanges. And I was also like, I live in San Francisco in the Tenderloin district, and there's a lot of drug use, and I was thinking that it makes sense for a lot of businesses and places that are open to the public to carry it as well.
I mean, that's interesting that business owners would carry it. I remember speaking to an addiction medicine specialist a couple weeks ago who told me that in San Francisco alone, since you mentioned that, last year about 1,200 people were revived due to naloxone, and not by paramedics or doctors or policemen. It was by regular folks. So it is clearly saving lives. Yes. And the Surgeon General came out recently too and said that everybody should be carrying it. Mm-hmm. So let's move on to the treatment options. There are 3 FDA-approved medications for treating opioid addiction, and they are methadone, buprenorphine, and naltrexone. 2 of them, methadone and buprenorphine, are actually opioids themselves. Today, we're not really going to get too deep into the details, or we aren't at this moment, actually. But if you have questions about them, please feel free to post them on our Facebook comments feed here. But that raises the question again about you, Brian. Tell us about your treatment. How did you get off of heroin?
Yeah, so during the years, I tried a lot of things to get off heroin, and at one point, I did do methadone treatment, and I had talked my parents into paying $500, which gave me about a month of treatment, and I had to go every single morning to the methadone clinic between, I think the window was like 6 and 8 a.m. And I wasn't the best. I wasn't the best patient. They said I could drink alcohol. That was okay, but I couldn't do other drugs. And so what I would do is I would just drink a lot, and then I would show up early in the morning. I'd get my dose, and I'd go home, and I'd usually pass out, wake up, and then figure out how I was going to score heroin, and that only lasted a month. But even if I wanted to keep going, which I don't think I did, I wouldn't have been able to afford it. Like, my mom she didn't even really know what she was giving me that money for, and I just couldn't come up with $500 a month to do the methadone treatment. And then, then the other one, which is buprenorphine or Suboxone, which is the brand name. I actually never had been prescribed it by a doctor, but I would buy it off the street. There's a big market on the street for those drugs, and it was always kind of like you buy it and you'd stash it away for that time when you wanted to get clean off or wanted to stop using heroin.
Oh, so people would buy it as a way to get off of heroin?
Yeah, kind of like a self-treatment plan, which rarely worked. But
right, and it sounds like methadone just didn't work for you.
Well, it didn't seem to work for me then, no.
Okay.
And then, go ahead.
Oh, I'm sorry. So if methadone and buprenorphine didn't really work for you, what did you do to get off of heroin?
Yeah, so I mean, like, the only times really that I had any time where I wasn't using heroin was like when I was in jail. And then there were some times when I was in a residential rehab. Usually those came after being in jail, so I would sometimes, kick cold turkey, as they say, which is without any kind of medication, and go through all those withdrawals. And then I would go to rehab, and that didn't work either. What happened was just one day I just had this moment of desperation, and I was like, I can't do this anymore. And it really wasn't the only time I felt that. Like, I'd felt that many times. But this time I packed my stuff and I moved back home with my parents, who had since left the town I lived in part to get away from me. And I showed up, and I just went through the withdrawals without medication, and I started going to 12-step recovery meetings. And
so you essentially got off of it without the medication, it sounds like, maybe to start, but then over the long term.
Yeah, I mean, I did, and I feel very fortunate and lucky that I was one of those people.
So Brian's told us a little bit about his experience, but you've also covered a lot of stories about people who are struggling with opioid addictions. And one of those, you recently wrote about a woman named Heather, and she went through this extremely harrowing ordeal, a 3-day bus ride. She was on heroin, right? And then she went on this 3-day bus ride from Chicago to the Central Valley and withdrew from heroin during that bus ride. And when she landed in Bakersfield, explain to us what happened to her.
Yeah, so Heather was in Chicago, and she just had that same kind of moment that I had, which was just like, I can't do this anymore. I need to go back home and live with my parents, and maybe that'll help me get off of heroin. And so she thought, though, the best way to do that would be to go through the withdrawal symptoms on the bus for 3 days and then show up and kind of have already gone through the worst of it and then start to like put her life back together. And what happened was that she just had this miserable experience on the bus where she just felt trapped for 3 days, just like feeling the sicknesses, the anxiety, the like cold sweats, and she had to like keep running to the bathroom in the back of the bus to vomit. And it sounds like a nightmare. Yeah. And just like the whole mental obsession of probably just knowing like, I know what can fix this, but being trapped. And then when she arrived back home, which wasn't Bakersfield, it was in Lake Isabella, but she arrived in Bakersfield from the bus, and then her mom drove her back home. And she found out that, like most small rural towns in America, it had a bunch of heroin, and she just went back to her old ways.
So she went through all of that on the bus, and then when she got home, the temptation was right there. But was there, I mean, could she get into treatment in Lake Isabella?
Yeah, I mean, so she arrived in this town and she still was sick. So she hadn't even gone through it all. So she still felt sick. She didn't have any medication to help. She didn't have any kind of professional support. And the town is a small town, and there was really no doctors who were willing to prescribe buprenorphine. There's no methadone clinic. There's no treatment in general, no like residential rehab around there. And so she just very easily fell back into her old ways. And what changed for Heather was that during that time she found out she was pregnant.
Oh, wow. That adds a layer of complication onto things.
Yeah, you can say that. Like she never thought she could have a child, and so she really wasn't paying attention to that kind of thing. And she found out at the emergency room in Bakersfield that she was pregnant, and that if the doctor told her if she wanted to save the baby, she needed to get on methadone.
And methadone, not buprenorphine, right? So tell us a little bit about methadone. You said when she got to Lake Isabella, there was no clinic. What do you mean by that?
Yeah, so methadone, there's a methadone clinic in Bakersfield, which is about like an hour and a half bus ride from where she lived. And what that means is like you can get methadone from these methadone clinics. It's the only place you can actually get opioid treatment from. But there's a lot of rules that come with that, and so you have to go every single day.
Wow.
And if you don't go, you can get kicked off the program. So you would have to adhere to kind of this really strict structure. And when you live really far away, it's really hard to get there every day. And especially when you're in those moments where you don't have a lot of support, where you're, kind of at your bottom, as they say, where you're kind of don't have secure housing, you don't have secure money, and to kind of figure out how you're going to get there is really challenging.
And so did Heather, the pregnancy happened, or she learned about her pregnancy, and she said that, and the doctor told her she needed to be on methadone. What happened to her? Did she manage it?
Yeah, so she tried to do it on her own at first, and kind of those things I was talking about happened to her, and she ended up not making it a few times, and they ended up kicking her out of the program, and she just she just didn't know what to do. She was fully addicted to heroin still. She was 4 months pregnant. And sorry, I got distracted for a second.
She was 4 months pregnant.
Yeah, so she was 4 months pregnant, and she's like, I don't know what to do. And then what happened was her mom stepped in. Oh. So her mom went to the methadone clinic and was like, I'm going to quit my job, and I'm going to drive my daughter every single day to the clinic until she's able to take the bus herself. And they let her back in, and so they started to do that, and she was able to adhere to the program, the treatment program, and started to get a lot better.
And did she have her baby? And
yes, she did. She had a baby, and it was healthy, and
great.
Had no kind of addiction to any kind of opioids.
Great. Speaking of methadone, isn't there some kind of stigma around the use of methadone? I've heard that some people think that because methadone is an opiate itself, that you're just exchanging one addiction for another. Could you address that?
Yeah, I could talk about that. Yeah, I've heard that a lot too, and there is a huge stigma around methadone. I mean, there's a huge stigma just in general around like drug use and drug treatment, and for Heather and her family, like they both had they both thought negatively or poorly about methadone and had those similar concerns that it was just trading one drug for another. And it's interesting, a lot of heroin users see methadone as that, and don't want to get on treatment because they see it as just exchanging one drug for another. And why not just actually feel the really booming highs of heroin instead? But what happened was, though, that they were at a desperate moment where they didn't know what else to do, so they were willing to try methadone because there was no other real option, and a doctor told her that it would save her baby. And what happened was they saw Heather change. They saw Heather change, and so they both became proponents of this treatment.
Could you explain briefly a little bit about? Can you explain a little bit about the fact that methadone and buprenorphine, which we'll talk a little bit more about, that they are opiates? I mean, people who are not familiar with them may not know that they control withdrawal symptoms, right? That they control cravings. Could you explain that a little bit, or what they're or they reduce the high?
Yeah, I mean, they help with the cravings, and they reduce withdrawal symptoms, and they help people kind of stabilize to have their behavior as well. It usually stabilizes after they've been on it for a long time.
And that will allow them to then, for the long term, to address the addiction, right? Okay. So we were talking about, she used methadone. What about buprenorphine? I mean, the way I understand buprenorphine is you don't have to go to a clinic to get it. You don't have to go somewhere every day to get it. Why didn't she just use buprenorphine? Yeah,
so, well, her doctor told her to get on methadone, but in her area, there was no buprenorphine. There was no physicians willing to prescribe buprenorphine, and that's how that works, is if you want to get that drug or that treatment, you need to go to a primary care physician is one way to do it, and they can prescribe it to you.
Actually, we just got a question related to this. Yes, it is exciting. And this fits because, like you said, in Heather's area, there were no physicians who were not qualified, who were allowed to prescribe buprenorphine. So the question is this: how can more physicians be brought in to treat opioid addicts, especially in rural areas? Why don't we first explain a little bit, Brian, about what physicians have to do to get the permission to do this?
So most public health experts agree that buprenorphine is one of the gold standard treatments for opioid addiction. And the problem is that there's not enough physicians who are willing to prescribe it. And part of the reason is because you have to get a waiver from the federal government, and it requires an 8-hour training session. And besides that, there's also this kind of, we talked about stigma, there's also a stigma of having to treat a drug-using population that may come with a lot more, baggage, if you will, like a lot more behavioral issues and things. And so there's a fear that it might disrupt a practice. And a lot of these primary care physicians already have practices where they treat patients, and there's not a huge incentive for them to do it. And so I guess what the question is like, how do we encourage more rural physicians in rural areas to be willing to do this waiver and willing to kind of treat this population? And there's a few different things that are in play in California, like the Department of Healthcare Services recently got a grant, a federal grant that it distributed to a little bit more than a dozen communities to support physicians in prescribing these and kind of giving support from clinics or other physicians who have already done it, so they will have training and help. So
physicians need more training. Is there anything being done to address the stigma that you mentioned that you know of?
Yeah, I think there are. I think there's some efforts to work with emergency room physicians, and there's a lot of outreach. I know that some of these methadone clinics, some of the ideas is they could set up maybe a satellite clinic in some of these small places, so it's not like a full clinic, but just a small room where people can go, because there's not they don't see as many people coming in as, say, more urban area like San Francisco or, even Bakersfield.
Right. And the satellite clinic, it would be by telemedicine or?
No, it would be just a smaller clinic where there's more physician, or it could be in conjunction with a primary care physician.
I see. Okay. And just a reminder, that was a great question. If you guys, anybody watching has questions, please go ahead and post them onto our Facebook page. In the meantime, Brian, let's move on to one of your other stories. You wrote a different story, but out of the same area, out of Bakersfield, that involved an addiction medicine doctor who prescribed buprenorphine, actually, and who ended up shooting and killing a former patient in his office. His name was Dr. Zong, I believe.
Mm-hmm.
Tell us about Dr. Zong.
Yeah, and I mean, this kind of goes into the last thing we're talking about, and the limited amount of physicians who are willing to prescribe buprenorphine. Dr. Zong was not one of them. Dr. Edwin Zong, he had an addiction clinic in Bakersfield, and he was willing to treat anyone who came to him, and based on my reporting and everyone I talked to, like, he took only cash, and it was like $50 to $80, and if you paid him that, he would write you a prescription for buprenorphine that you could then take to the pharmacy and have it filled however you would have it filled, either through, like Medi-Cal or out of pocket. And what happened was he ended up getting overwhelmed with patients. Like, he had lines out the door, according to neighbors and other patients, where it was just like a nonstop kind of assembly line conveyor belt of just like people coming in and getting this drug. And he at some point started carrying a gun. He got a carry conceal permit and brought a gun to the office. And one of his former patients, David Cole Lang, he was a vet. He'd spent 3 tours in Afghanistan and Iraq, and came back and got addicted to heroin and some other opioids, and just had a really hard time. And he, for some reason that we still don't know, went to see Dr. Zong and attacked him. And during that attack, the doctor pulled out his gun and shot him 3 times, 3 or 4 times. 3 times he got shot and died.
3 times. And what did the police determine about that case?
Well, the police determined that it was self-defense because he was attacked and acted in self-defense, according to the police.
I mean, that's a very extreme case,
Sure.
right? But the way you're describing it, with patients out the door and this assembly line, it sounds like there's just a much bigger need for this service than there are doctors. Is that what the moral of the story, essentially?
Yeah, I mean, I think that there is this lack, but there's a great need for it, as we can see, and illustrated by the Dr. Zong story, was that there's a lot of people who are on opioids that want this medication, and they want it for cheap, and they want it easily acceptable, and maybe those don't always go together, and so yeah, there is a need based on just a lot of heroin users who want access to these medications.
Before we go on, we do have another question. Brian, I'm going to need you. What does SUD stand for?
It's substance use disorder.
Oh, there you go. Okay, so the question is this. The majority of people in jails have some sort of substance use disorder. Why is it the one place where effective medications are prohibited? So I presume they're talking about, is it methadone and buprenorphine are prohibited in jails, or?
Yeah, I think that's what they're talking about. I'm not super familiar about it, but I do. I mean, there's a lot of things about jails and prisons and incarceration, and there's not a lot of. You wonder why there's not even more rehabilitative services, and this is one of them. And it would make sense to treat a drug-using population that end up in jail and help support them and stabilize, and then continue to help and support them once they get out of jail. And I think some of the reasons why that's not being done, there could be a lot. I think some are it costs a lot of money to do that, and there's a potential for abuse that the jails might be afraid of.
Within the jails, like
yeah,
within
the jails.
You mean using buprenorphine for the as a drug as opposed to a treatment?
Correct. Like it could be sold and traded.
I see. So a potential
kind of thing, or
potential for abuse then. Okay. And actually, you mentioned this a little bit earlier. I wanted to follow up on it. Medi-Cal. Can you tell us a little bit about? So Medi-Cal is California's version of the federal Medicaid program for low-income Californians. What kind of coverage and access do Medi-Cal patients have to these treatments?
Well, they do have a lot of access now, and it's kind of changing, and it depends on what county you live in California. But throughout the state, if you have Medi-Cal, you can go to a primary care physician and you could start a treatment plan with buprenorphine. In some counties, methadone clinics, which are regulated by federal and state laws and have a lot more regulation around them, and some counties are now being able to accept Medi-Cal for buprenorphine treatment, which includes counseling and a bunch of other kind of services.
Supportive services, and you can get that at a methadone clinic.
Correct.
I see. So it sounds like, and wasn't there something about naloxone? Is that available as well? Am I
Naloxone or the...
No, naloxone.
Uh-huh.
Do you know about coverage for that for Medi-Cal patients?
I don't.
I apologize. I don't have the answer off the top of my own
maybe
head.
someone listening can type in.
Actually, that would be great. That would be great. And you mentioned something about how Medi-Cal patients, if their primary care physician, they can get buprenorphine from them. My last column from last month was offering tips and resources to people who have addictions, opioid addictions, or their loved ones. And I'm going to ask one of our producers to post my column. And if anybody's interested, you just go to the column. There are several links. You can search by zip code for the doctors in your area who prescribe buprenorphine. You can also search for addiction medicine specialists who can help guide you. And so hopefully that would be helpful to some people. It looks like we have another question.
Yay.
Keep them coming. This is a good question. I'm not sure that I have the answer.
I'm not sure I do either, but
okay.
we can address it, though, I think.
Okay. The question is this. How can we approach pharmacists and request them to prescribe to and educate opioid patients? So it sounds like the question is not just about doctors and the stigma with doctors, but with pharmacists as well.
Yeah, I mean, I'm not entirely sure what the question's asking, if pharmacists should spend more time educating people who get opioid prescription pain pills, or if it's about treatment or what. But during my reporting for the Dr. Zong story, I talked with a lot of pharmacists, and it appeared that a lot of pharmacists have a criteria of what they look for in drug-seeking patients, and if they see enough of them coming from certain doctors, they could flag those doctors as being sketchy provider or sketchy prescribers, or just refuse them altogether. So I don't think that answers the question, but
that's okay.
I think it was an interesting thing about pharmacists.
Yeah, and I wish I knew more. It sounds like I'm wondering though too if naloxone, for instance, is available in California and most states without a prescription. I wonder if pharmacists have a choice, for instance, in whether to carry it. That I don't know the answer to, actually. So if anybody knows, let us know. Another question for you, Brian. What surprised Brian most while he was reporting about substance abuse treatment in California?
Well, let me think. What surprised me? I mean, I've been reporting and been a part of the recovery world and been a drug user myself, so not a lot of that kind of stuff surprises me. I think what was most hurtful was what really touched me the most was doing the story about Dr. Zong and the former patient who was killed, which was Cole Lang, and it was just a really sad story about him coming back from 3 tours, and like it was just like all that stuff you hear where they just struggle to find help and they struggle to like ask for help, really, and they have those things like where they say like, oh, he'd say like he was, a soldier, he doesn't want to admit his problems, and you're like, you just have heard that for so long, and you're like, I can't believe that's still like, there's not enough outreach or help that kind of reach these people and give them the encouragement to share, because it just was really sad, and that's what really like touched me, and that he just couldn't find the help, and he had a really hard time at the VA, in the Central Valley area, according to his family.
Actually, this is a good place to ask you what other stories on opioid-related coverage are you looking into, or would you like to look into that you think need attention?
Yeah, I mean, just like I was thinking about it, but now it just seems to be coming off the top of my head. I'm interested in the state and how its Medi-Cal program, they are doing a lot of stuff that's unfolding right now in California, and how they address drug treatment in general, including opioid treatment, and it's really transforming the whole system. And so I really want to kind of dig into that more, and it's not only is it...
Oh, you mean it's filtering kind of beyond Medi-Cal into the private insurance world? Is that the idea? Or?
No, it's just changing how treatment is administered, because a lot of times people went to residential rehabs, and that's changing, and they have
that's
different views about the best treatment now. And I don't know. And so I think that's a good way to look into it. I'd also think it's interesting to continue to look into the companies that make these opioid treatments, and while they do save a lot of lives and help a lot of people, they are pharmaceutical companies that are driven by profit, and there's a big incentive for them to continue to make new formulations of the type of drug so they can continue to get which is a higher, they get charged a lot more. And so I would like to dig into that a little more, and I think that's
an interesting point, because I know naloxone, for instance, when I was doing my reporting, and you probably know more about it, naloxone is available in 3 different media, I guess you could say. You can get it as a regular old syringe in a vial and inject it into someone, which is kind of scary, actually. But, you do it if you need to.
Well, heroin users that are IV users are familiar with it.
Right, but if you're a family member or something. And then you can get it as a nasal spray. And then the third option is this kind of auto-injector EpiPen-like device. And I think the price of those is increasingly expensive, right? And so with that EpiPen device being the most expensive. So is that the kind of thing you're talking about?
Yeah, that's what I'm talking about. And with like buprenorphine, they have like, it was a tablet, then it was a tablet mixed with naloxone to prevent like kind of an abuse deterrent, and then it was, a film strip, and then they have an injection, and then there's like another kind of, I think they call it depot injection, where they inject something in you that then releases the buprenorphine over a time period. So there's just more and more. It's a big industry, and there's a lot of money to be made too, as well as ways to. And also, it's trying to help and treat people as well.
Right. I think that's fascinating. That's fascinating. You had mentioned something to me. We have more questions. Okay. Here's a question. Can you please comment on a recent study about the quote, moral hazard, end quote, of naloxone, which said that precisely because it can save lives, it encourages people to feel less inhibited about using opioids, which leads to more overdoses, thus offsetting naloxone's beneficial impact. That's really interesting. So the idea is if people know they won't die, they're more likely to keep using, I think. What do you think about that?
It's a tricky question. Through my own experience as a heroin user, like I could totally see how having that would increase, you'd be more willing to take chances.
Right.
And, that makes sense, but that's not an excuse to limit the access to something like this, because it saves people's lives. And like, whether people are taking riskier chances or not shouldn't matter, like this is a thing that reverses an opioid overdose. It saves lives, and I think that it's important to give that to the people.
Interesting. Did you hear anybody? Have anybody you've interviewed talked about naloxone and using it?
Yeah, everyone I've talked to that has been an opioid user has some story, usually some really sad, horrible story of someone overdosing and dying. And sometimes there's people who have administered naloxone and saved people's lives. But.
Okay. I do. There was a gentleman named Patrick actually emailed us some questions ahead of time, and one of them goes to the question about why more doctors are not prescribing buprenorphine, and he wants to know. He asks about the limits. Apparently, there's limits on physicians who have been approved. They've gone through the training and they got their approval to write buprenorphine, but there's these limits. Can you explain those?
Yeah, so there is some more hurdles and barriers to get access to buprenorphine, and besides the waiver, there's patient limits, and those have been changed recently to allow for more patients. But I think when you get the waiver, you apply to treat 100 patients, and then after a year, you can get a jump to about 275 patients. And I also think that also allows for not just primary care physicians, but also nurse practitioners can prescribe it.
So the kind of provider is maybe broad, but the number of people is limited.
It is limited, but 275 is still a lot of people for one
doctor
physician.
But why do they do that? What's the reasoning behind it?
I don't know. I think that the idea behind all the limiting is that they're controlled substances by the federal government, and they want to control them.
them.
Yeah, they want to control them,
Right.
and they don't want them to be abused. And they, I mean, like,
Right.
it's the war. You know, there's still a war on drugs. It's like the war on, you know.
Right.
I don't want to get too into it.
Right. You don't want to talk about the war. You know, you talked about rehab a little bit earlier. And this is something that came up in my little amount of reporting on opioid addiction when talking to addiction medicine specialists. But I'm just going to pose it to you.
Okay.
Does rehab alone, without the use of methadone or buprenorphine or naltrexone, does that work? Can people, it work? I mean, you didn't do rehab per se, but you didn't use medications. I mean, does rehab alone work?
Well, I mean, a lot of people say that it doesn't work. I guess it depends on what you hope to expect to get out of rehab. Like, you can think that, like, anyone besides opioid users who goes to a treatment place for a small amount of time, and to think that, like, being there is somehow going to stop possibly 10, 20 years of drinking, using, or whatever, is kind of not realistic.
Mm-hmm.
Yeah, I think that there is a change, though, in residentials, that there's been more of a move to incorporate medication-assisted treatment, whether they bring that on themselves or whether they work with other kind of doctors and the patients who come there. And there's also a move to actually limit the amount of residential time that people do in general, so that they can have more access to outside kind of treatment that would allow for a more robust kind of medication treatment. So I don't really know how to answer that, but I mean, a lot of people say it doesn't work. I mean,
yeah, it's interesting how adamant that the doctors that I spoke to were about that nor did they said rehab alone didn't work, but they also said medication alone, for the most part, shouldn't be the treatment of choice. It should be combined with 12-step programs and other support therapy, things like that.
And counseling, yeah. Yeah, I mean, like, what's crazy about this is that it's just a really, like, interesting world of drug use and treatment, that, like, there are some things that show that help, but we don't really know a lot. You know, I mean, There's a lot of research and still, like, a lot of money that's thrown at this, and we're still, like, you know, how do we reach a drug-using population and get them to get treatment, you know? It's still a big challenge. And sending someone to rehab, you know, it's like they say, it's like a lifetime thing almost, to continue to stay off these type of drugs. And that's why there's a lot of, like, methadone. We didn't really talk about the lengths of time that people are on them, but, like, in the story with Heather, like, I think over 3 years she weaned herself off, or to a really low dose. And that just means she tapered the doses. She went up to a peak and then went lower and lower and lower until she was basically on very little to zero methadone. And that was over 3 years. Some people stay on it forever. It's called methadone maintenance, or indefinite, until they're ready maybe to wean off. But I know in San Francisco there's, like, slots for methadone, and people just stay in there until they die, usually from old age. But
Interesting. So that's right. And you're touching on something that I heard as well, is that people could be on these medications for years, if not their entire lives, and that we as a society should be looking at, and as individuals with loved ones should be looking at substance abuse disorder as a chronic condition, like you would look at diabetes or high blood pressure, and that you shouldn't expect, like, some overnight or short, you know, miracle.
Yeah, and that's kind of like some of the advocacy around treating this, that's trying to be explained to a lot of physicians, that it can be treated like a chronic condition, and that after the initial kind of period of getting them off of the street or illicit drugs onto a stabilizing on the medication, that they can just come in regularly with a doctor as they would with any kind of other chronic condition. And that it's not really much more than that. And it also, you know, we look at it as a disease instead of, like, the classic of the moral failing of which is a common kind of dialogue that people talk about. But it looks like we got a confirmation on.
Great. So somebody, thank you. I don't know who you are. You confirmed that naloxone is covered under most insurance plans and covered by Medi-Cal and Medicare. So thank you for that. You know, folks, did you want to add something?
No, I just said that's great.
We're going to be wrapping up pretty soon, unless you have some last-minute question you want to slide into the Facebook comments. But is there anything you want to add here at the end, or?
No, I mean, I've been talking a lot. I mean,
you're exhausted.
No, I'm not exhausted. I'm enjoying it. I'm just,
Yeah.
I mean,
No, I really appreciate you. You have a unique perspective. You know, you have the personal experience, and thank you for sharing that, which may not be the easiest thing in the world to do, but you also have the perspective of a journalist who's spoken to so many experts and real people. So thank you. Thank you for doing that. Oh, I think we have, no. Oh, okay. No more questions, you guys. I really appreciate everybody who has joined us today, and this is California Healthline's first Facebook Live. If you have ideas for future topics, please do let us know, and we will see you next time.
Bye.